block on the right and also on the left on a pleasant 67-year-old lady with what is a grade 3 contracture on the right and a grade 4 contracture on the left. This is the capsular contracture. These are implants from 1988. So as you can see down here, they're very hard and blood loss was minimal. And as you can see, inflamed tissue side and an outpouching right here. And you can see some areas are relatively very, very thin. Some areas are a little bit thick because I had to incorporate what is this inflamed tissue. Remember, whenever there is any implant, even an intact implant, that capsule forms, and then there is that gel bleed phenomenon that occurs, some more, some less. And then in her case, as you will see, look at this outpouching right here. So this is the inflammation that spills it into the periphery. So it is important to not only include the implant and capsule, but this inflamed tissue around because it's abnormal. So what I'm going to do is just to show, look at what I was dissecting, especially this area, for example, right here. I'm going to go in very meticulously. I want to dissect bluntly and sharply right here and see exactly what we're dealing with. Look at this outpouching right here. So this tissue right here is abnormal, bad, and this is where, if from my experience, if this tissue is left behind right here, you can see it's dusky appearing. It is dusky appearing. It is not healthy tissue. One way to do it is send this separately to pathology to show exactly what I'm talking about. But you will see, I don't want to have her to get tooth pathology samples. This is again part of the inflammation of the capsule. And you can see this bulge right here. And let me go in here. You can see how this, what appears to be this gray dark spot. So this is a very thin area. Remember, the whole end block is done. There is no spillage. And it's relatively soft in some areas, like here as I press. So I'm going to go ahead and go in from here. She had grade 3 capsular contracture on the right side. And as I go in, you can see right here, all contained hard calcified tissue. And this is indeed what is a ruptured implant. And she's had this for, I would say, this hard capsular contracture for decades. She's had implants from 1988. 36 years later. And as you will see, I'm going to go ahead and remove this. And you can see how it is suffocating this implant. And we've seen this many times. All contained ruptured implant. None of this spilled into the chest. And as you can see, if I invert this open, you will see what falls out. It's this tissue. You don't want any of this to spill into the chest. And you can see this is that capsular tissue. And as I move this out, it's like the scales of a fish. I want to show this one. You can imagine how hard this was. I can just snap it. You can see how all this tissue is. And it's like cement, like plaster of Paris. So all of this I'm going to send to pathology. And you can see the aftermath. Implants are not meant to be in the body forever. This is what the body does in order to protect itself. And the ruptured implant, silicone, what appears to be smooth surface. I'm going to go ahead and change my top glove. And then I'm going to focus onto the left side. There's some tissue that I removed that was abnormal. So 1988, right and left, grade 3 contracture on the right, 67-year-old female. So as you will see, again, right here, here's the implant. There's the tissue. The left side has significant inflammation, just like the one on the right, but much, much more so. And as you can see, I'm just finishing up on the first case. I'm always amazed by how surgeons can do the entire end block and the lift in 3 hours, where I just alone did the end block in 3 hours or possibly more time. The other thing I want to show you here is look at this nice round surface. And then here's a bulge. Nice round surface, and then here's the bulge. So I'm going to go ahead and take the time to dissect here, just like I did bluntly. So let me come here. So I want to show the one thing that I want to show here is you see this area right here. This is the very tricky part. You can see there are breaks in the capsule, and if I go in, it doesn't take much to cut into. So let me go ahead and go into this area. It's hard. It's extremely hard right here. So we will see what it shows. What appears to be a focal spillage. None of the silicone spilled into the chest, and no need for drains because all of that abnormal tissue was removed. I'm just following this around, and as you can see, this is the inflammation. And I'm going to show to you, I'm still kind of within the capsular tissue, but this was what appears to be a focal spillage. And this is that hard mass. So you could potentially say, well, this is still the capsule, but this is that spilled over silicone. Look, what is classic silicone granuloma? And I'm dissecting right on top. And the point here is this hard mass right here. You can see I'm having a hard time cutting into it. It's hard, like petrified wood. And you can see there's silica in it, even though this is part of the capsule. So what I'm going to do is I'm going to clean my scissors. And let me go into this area because this is another outpouching. I'm going to look at this. It goes like this and then a hump right here. Again, the same thing, what appears to be a focal rupture. So you can see, look at this tissue. This is a silicone granuloma right here by gross visualization. And now pretty much what we saw earlier. And let me go into this area. So right here, as you can imagine, if you're going fast and you're dissecting, and accidentally, if you go into this area, you can see how thin this is. This is soft area. You can see a ruptured implant again. And not surprising, just the fact that it's been there from 1988, a very high chance for rupture. So they're going to open this up here. Literally, I'm going to lift this cap up, and here you have that ruptured silicone again. And let it fall out. And the same thing we saw on the other side. If I pull this open, very, very inflamed tissue. Look at all of this hardness. And if you can only imagine how hard this area is, all of this area, you don't want any of this to spill into the chest. Now it's a mandatory drain. It's a lot of inflammation, potential seroma, and whatnot else. And so N block is indeed what is the gold standard. So I'm going to go ahead and invest this here and look at all of this tissue. So I'm going to send all of this tissue with respect to the left side. So this is again what we see with the gel bleed, and obviously a whole lot more with the ruptured implant. So N block, the gold standard, no other better way of doing this. All contained, all the badness inside is contained, none of it's spilled outside. All of it is removed with the implant, the capsule, and that inflamed tissue around. And in this case, what is a silicone granuloma? And you can only imagine the hurt that it was causing. She had a grade 4 contracture, which means visualization of the left chest shows abnormal deformed chest breast tissue with a capsular contracture riding high, displacing the nipple, causing pain. On the grade 3 contracture on the right side, she had pretty much the same, but no pain on the right side. So the pain makes it a grade 4, and no pain makes it a grade 3, and hard like rock. Capsules plus the implant tissue completely definitively removed. So the implants will be returned to the patient. Capsules sent to pathology, rule out the BIA LCL, rule out BIA SCC, rule out malignancy, rule out any abnormal pathology. Cultures done for aerobic, anaerobic, and fungal. No need for a lift in this patient right now with this severe inflammation. no need for drains, twilight sedation, and then complete removal of the whole implant capsule, inflamed tissue, regardless of her age. So she gets the same surgery that a 27-year-old patient that I operated on yesterday got. And the end block, the gold standard. 20 years from now, I cannot imagine anyone else doing the surgery any more definitively, any more completely. And now the patient has the peace of mind that everything was done in a very systematic, thoughtful way. And we look back at it, it could not have been done any better. Please share. This is Dr. Khan, executive plastic surgery. Implants are not lifetime devices.